Testing webcast, 1, 2, 3, testing. Testing webcast, 1, 2, 3, testing. Testing, 1, 2, 3, testing. Testing webcast, 1, 2, 3, testing.
Are we ready, Richard? Okay. Good morning and welcome to the Health and Adult Social Care Scrutiny panel. This morning's meeting, we've got 3 discussion reports and 1 written update on TB to look at. So can we look at the minutes of the previous meeting then, please? Do the panel agree the minutes of the previous meeting? Are those moved? Yes, thank you. Anybody got any comments or anything they wish to raise on those? Does anybody have any interest they wish to declare?
On the waiting list for a wheelchair. We've got family members waiting on the waiting list.
David? Thank you. Right. All items are to be held in public, so we agree that the public can be admitted to the meeting. Right. Item 4 then. Update on the financial positions of Greater Huddersfield CCG, North Kirklees CCG, Mid Yorkshire and Calderdale. If somebody can start off, we've obviously read the report through. If you want to say anything before we start asking questions, that's fine. If you want to say who you are before you start speaking, that would be very useful. And don't forget to press the big button to turn it on and the small button to turn the microphone off. Okay? All right.
Lovely. Thank you. My name's Ian Corwell. I'm Chief Finance Officer for Greater Huddersfield CCG, an interim Chief Finance Officer for North Kirklees CCG. Should we all introduce ourselves first, maybe?
Good morning. My name's Pat Keane, and I'm Chief Operating Officer for North Kirklees and Wakefield CCGs.
Hello, my name is Martin Barclay. I'm Chief Executive at Mid Yorkshire Hospitals NHS Trust.
If it's okay with the committee, I was going to do a sort of, or 3 of us going to do sort of a 5-minute introduction, but no more than that, and then we can get into questions if that's helpful. So I'll start off by giving a quick overview for all organisations, and then just a little bit more detail about my 2, Greater Huddersfield and North Kirklees, and then Pat will update for his area, Martin will just do a quick update for his area, but I'll say no more than about 5-10 minutes in total. So you've got the report. If you go to page 1 of the report, that gives an overview of the financial position for the 4 organisations. So section 2 goes through the detail of that. The table under 2.1 shows for the 2017-18 plan for the 4 organisations, we all planned for a deficit for this financial year. So the total across all 4 is 21.5 million. Third column along, 17-18 forecast outturn. For the trusts, that's at month 8. For the CCGs, that's at month 9. Both CCGs are forecasting to be off plan The two trusts are forecasting to achieve their plan, although there's significant risks that they're facing, and I'm sure they'll update on that in a bit. But if you take all four together, we're forecasting a total deficit of 37 million against a plan of 21.5. The report then does a bit more of the detail around the position, and then if you go to page 2, top of page 2, as part of our financial planning process, in order to hit the targets set by a regulator, we have to set a savings target, and in effect that's the balancing figure from our funding versus what we think we're going to spend. Again, across all four organisations, we had a total savings plan of 73.3 million. All four organisations have made significant savings and made really good progress. But if you see from that table, no organisation has achieved their plan in full for the savings target. And if you add those four together, we've achieved forecasting to achieve 51.9 against a target of 73.3 million. Rest of section 2 does a bit more about the position, and then if you go to section 3, which is page 4 of the report, that starts to get into what we're doing as organisations in order to address that financial position. We've always done that as individual organisations. We've always had our individual savings plans. We're statutory organisations, so we continue to do that. But what is increasingly evident, A, for the finances and B, for outcomes for patients, is we need to work together really well in order to achieve the scale of savings that we need to find. Kirklees is a complicated footprint, one local authority, 2 CCGs, 2 acute trusts. So quite what should we plan on? So at the moment, around our savings schemes, we're doing it on the 2 acute footprints. So Greater Huddersfield CCG has done a joint system recovery plan with Calderdale CCG and with CHFT. And on the other side of the patch, North Kirklees CCG has done a joint system recovery plan with Wakefield and with Mid-Yorkshire. And then just a little bit more on my 2 organisations of Greater Huddersfield and North Kirklees. Greater Huddersfield CCG last financial year, 16-17, had a deficit of 5.4 million. This financial year, we had a target to get that down to 1.2. Current forecast is 3.3. We haven't given up hope for the end of the year to get that down to plan, but that is really difficult. So although disappointing that we may end up being off plan, when you take year on year, that does show that we're starting to turn that around, and that is a real improvement, taking 1 year with the previous year. For North Kirklees CCG, more challenging, 8.9 million deficit in 16-17. In 17-18, our regulators required us to really turn that around and drive that down to a 1.2 million deficit. That was a really ambitious plan. Our forecast at the moment for year end is 15.5. So that is a significant variance to our plan. We're therefore having discussions with our regulator, NHS England, and are in a process with them. But we absolutely need to start turning that around quickly, and the system recovery plan that we'll talk about later is really crucial to that. And then just finally from me, the system recovery plan for the CHFT footprint. Been working together for a long time. We started to put that into a system recovery plan in the autumn of last year. We have target savings, set ourselves a target of 16 million of savings as a system over and above what we do as individual organisations. So far we've identified 12 of that 16. That plan is in draft stage at the moment. We've also been revising our joint governance to get that really good and a lot slicker. And that system recovery plan, we aim for that to become public in the new financial year. So we will be going through a public process around that. And of course the individual schemes will go through as needed, whether that's consultation, engagement or whatever. So just a quick update from me. If I just pass over to Pat to give a quick update around the Mid-Yorkshire recovery plan.
Thank you, Ian. So on section 3.3, just very briefly, just a couple of things I wanted to highlight, and happy to get into more detail. First thing is that system recovery, so that does mean North Kirklees, Wakefield, CCGs and Mid-Yorkshire working together. That is because of that key issue in the second sentence there about the codependencies. So we commission the majority of our acute services for North Kirklees and Wakefield from Mid Yorkshire NHS Trust. So any decisions around investment, disinvestment, transformation will have an impact on Mid Yorkshire Trust, but therefore also have an impact upon the population of North Kirklees and Wakefield. So we recognise that any decisions that we make, we've got to be as joined up as we can be within that process. So we established a joint recovery approach in the early summer of 2017. We've established governance arrangements working through both CCGs with the Trust. I suppose the key things to highlight, Chair, and that is that recovery, yes, it is about financial stability and recovery, but as outlined in the objectives at the bottom of page 6, it's also about quality and delivery of standards and constitutional targets. And that is really important. And certainly we've made it clear in our planning and delivery process from our system recovery that we focus as much as on 18-week recovery, A&E performance, diagnostics, etc., cancer targets, as we do on financial recovery. Clearly, there is a key challenge as a system in working towards financial sustainability and delivery when we've got such pressure on the system from an activity perspective. And so it's really about how we work as three organisations and our wider partners in terms of addressing the significant quality issues that we've got to address, but also recognising we've got to deliver some significant financial savings. That is a challenge for us all, and we're working both with, as Ian suggested, working with our regulators, that's NHSE for CCGs and NHSI for the Trust, to understand the scale of the challenge and how we move forward. And finally, Chair, in that second paragraph, recovery will not be delivered in 1 year. And we're setting out, we want to set out a 3-year recovery plan, and we're starting to have that conversation with our regulators about what that might look like. But even at the end of 3 years, we recognise that there remain significant risks in working within that current financial environment. So just to assure you, Chair, we are working together as a system. We are committed to working as a system, but we don't underestimate the level of the challenge, both financially and from a quality and performance perspective.
Thank you, Chairman. From the Trust point of view, the disappointing thing about our financial performance this year is that on a like-for-like basis, we are about 5 million worse than we were at this time last year. And primarily that has been due to two things. One is our failure to identify ways of reducing our cost base in ways that we feel is achievable without having a negative impact on patient safety and the access standards that Pat has just mentioned. And the second thing is that our expenditure on agency staff has gone up instead of down. And since April, the average cost per medical shift has gone up as well. So in the last 3 months, we are booking less shifts than the same period last year, but the cost per shift is higher than last year. So in cash terms, the whole thing has caused us about another £3 million worth of expenditure, worse than last year. So it's been a multifactorial thing. We ended last year with if you strip out all of the funny money, we ended last year, roughly speaking, with a 20 million recurring deficit. We believe the excess costs of our PFIs are about 20 million a year. And no amount of good management is going to get rid of that excess cost. So for me, success, reasonable performance is keeping the recurring deficit at 20 million. But as I say, very disappointingly, we failed to do that this year. It's probably about 5 million worse than that, is what the end of year is looking like at this stage. And as my two colleagues have said, happy to take any questions if there are any.
I think we just need to say, don't we, that somebody from CHFT was asked to be here, but they haven't been able to manage to get, and because of illness or pressures, that whatever it is, that is perfectly understandable at this time of year if they haven't been able to get to the meeting. Okay, all right. So, do panel want any questions, David?
Thanks for the outline there. It's very clear that the current financial situation is very, very difficult, very, very severe. And I think given the need to have made savings over each of the last 6-7 years, the cumulative impact of having to save in that way begins to tell. There are a number of references in the report to the difficulties, and I just wanted to highlight a couple. On page 3 and 4 of the report, so that's page 13 and 14 of our document, it refers to the likelihood that the forecast will move away from the control total deficit at the end of quarter 3, which will consequently drive the loss of STF income. So there's a kind of significant point in itself. Second one I want to pick out just a bit lower down. A number of the recovery actions are non-recurrent and will therefore drive a further challenge into 2018-19. So it's looking at ways in which money can be saved just now, but it's storing up a problem for further down the line. And in paragraph 3.2 on page 5 of the report, there's a clear recognition in the Calderdale and Greater Huddersfield system that our current care models are unaffordable. So just 3 little sentences picked out from the report as a whole to indicate the seriousness of the current financial position. My question really is, I mean, it just looks to be unsustainable financially. I'm not sure ultimately what the regulators' view is, and we're both regulators for both the CCGs and the trusts. But I just wonder whether you get an impression of how things may work out over the next 2 to 3 years. To my mind, it just looks unsustainable. I don't see where the savings are going to come from.
Yeah, thank you. From our regulators' perspective, there's a national funding formula. We will all have different views, but around the country we'll have different views. But the formula says we get our fair share. There are a decreasing number of organisations in the NHS that are achieving their plan, but there are still some organisations that are in balance. So from a regulator's perspective, there are no excuses. You get a fair share of the national funding. We need to get back to balance, and that's our drive to do that. You'll know as well as I know from the national press about national politics and what's happening with funding. The budget recently announced, I think, it's an extra 2.8 billion for the NHS over the next couple of years. We haven't had details yet of how that's going to be allocated out, but that is obviously going to help us to get back to balance. But equally, the pressures keep going up and up. And when you look at January this year, I mean, Martin would better give a view from the trust perspective, but CHFT are coming back to us as a funder, and I'm sure Midgill's the same pressures around the rise around non-elective work and the extra costs of this winter, and that seems to keep going forward. So it is getting more and more difficult each year.
Just a couple of things. I think going back to Ian's point, rightly or wrongly, we are tasked as CCGs of working within a financial envelope, and we are tasked with doing that. That's our legal responsibility. So as soon as we move out of that position, we come under scrutiny, and we are certainly, from an NHSE perspective within CCGs, coming under increasing scrutiny. The issues for us, I think, as CCGs, as organisations, are we doing everything that we can and should do to address the underlying financial challenge? So, question mark, NHSE will be working with both CCGs over the coming month to look about, understandably, about capacity and capabilities. So in other words, are we as CCGs, have we got the appropriate skills base? We would expect those questions to be asked. So we are up for that conversation. We are then reviewing the underlying pressures. We work very closely, certainly from a Mid-Yorkshire perspective, with the Trust, but also remembering that a lot of the pressures associated with the acute sector can be looking back to pressures in primary care, in community care. So looking at solutions is not only about working with the acute trust specifically, but it's also working with our other partners to understand what we do see is an increasing, a change in demographic. We know that we've got an increasingly ageing population, but so as many other parts of the country, so we need to understand, are there any specific issues that we're not addressing in terms of the vulnerable population? So there's very much a look at how we are managing services outside of hospital. So that's one of our key focus. So we are doing, the word is transformation, which is used. So can we do things that improve quality and hold cost or reduce cost? That's the nirvana. What we're seeing at the moment is we haven't had the success in doing that. Certainly in Mid-Yorkshire, we've, over the last 3 or 4 years, had a major transformation programme, Meeting the Challenge, which has been successful in aligning acute services more effectively in terms of elective and non-elective. But what we haven't seen, which was the original business case, was the level of financial savings associated with that. So I think that's the shorter answer is we are looking more currently at a 3-year financial plan. We understand, we've modelled what the likely scenario is if we don't do anything significant, and you'll have seen the numbers are large. So as of today, we are in the middle of our planning process for 18-19, 19-20. We are under significant scrutiny from our regulators, but we want to work with them to understand the level of pressure. But we don't underestimate the challenge. But the bottom line is we have whatever the financial challenges are, our responsibility is to manage within that resource.
Thank you. Really, to carry on from what we've been talking about, I think we're all very sympathetic to the position you're in, and we can all see that whilst you're doing your very, very best under the formula that you're given, which you've no control over, to wring the very most out of the system, and that's very laudable. But the way it seems to Joe Public is that you're not being funded adequately under the formula to really cope with the issues. Hence, we're in perpetual recovery. And yes, it's good to have transformation, but sitting here, you can't see where transformation ends and conjuring begins, quite honestly. And really, to go back to the fundamentals, what it looks like, as I said, from a public perception, is that yes, you're getting new money every year, and it's true, there is growth, there is total new growth, but it's not real growth because it's not coping with the inflationary demands, wage costs, pharmaceuticals, and so on, and it's not coping with population demand. So yes, I mean, it's not meant to be a statement, but I mean, do you agree that you're not being funded adequately? You're getting new money, but it is not fulfilling real demand.
That's probably a slightly tricky one for me to comment on, really. But I mean, just pick it up. Is it real growth or not? So next financial year, the 2 CCGs will get approximately a 2% increase in allocation. So next year we will get a real cash uplift, more money for the local NHS. And equally, if we do nothing, our pressures will grow by more than that for all the reasons we know about demographics and all the other things. So we're in a perpetual cycle of having to be more and more efficient every single year to stand still. But, in my role and the role of those people employed by the CCG, that's what we need to do. And it's a sort of national politics question around should the NHS get more funding. But, we're all passionate about the NHS and we would all want more funding to come into the NHS, and we know there's loads of good stuff we could do with it if we get more money.
Can I ask then, the money that you're meant to get for transformation, right? So you've got some monies for winter pressures and etc., etc. But there's some monies for transformation in there as well, isn't there? Through the Better Care Fund and things like this. Is the monies for transformation in the health and social care system at this moment in time in Kirklees, is that being used for transformation, or is it being used to support the current system. Do you know what I mean? So how much is actually available to transform, to help you move forward? If the word is transformation, which we're very familiar with in these scrutiny panels, then how much of those funds that are meant for that are being able to be used for it? Perhaps that's a different way of asking the question.
Certainly for Kirklees, we are not getting significant non-recurrent pump priming money for transformation. There's an amount that's come out for winter, but that's not for transformation, that's for coping with winter. There's a recurrent national allocation for the Better Care Fund, but again, that's not pump priming new money. That's helping to fund all of our recurrent year-on-year schemes. So the real challenge, absolutely, Chair, is given that we're spending all of our allocation and we're spending a bit more because we're in deficit, how do we ever get the headroom to say, actually, we really want to transform, we need some one-off money to pump prime, we want to try and do service A in a different way, and there are double running costs, we need to try something different. We do not have the headroom in our allocation to do that. That just drives us further into deficit in that year.
Yeah, I wondered if I could just pick on a little pedantic practical point, which is 3.2 in your report. And, you know, you've said that there are, and just, you know, again, for illumination of Joe Public, you pick on 4 areas of how you'll improve the unaffordability of the current model. And I just wondered how, in practical terms, for example, shifting planned care services into the community, I wondered how will that save money, please?
Moving services from the acute setting into the community. We know that acute beds are scarce. We know that acute beds are expensive. We know they are highly skilled, not enough staff within our acute hospitals, and we equally know there are things that they do there that actually they don't need to be doing, and they can be done in the community. They can be done by other staff. Just taking example in both CCGs, MSK services, traditional model of all pay, be it back pain or other areas. Once your GP says, I cannot cope with this anymore, you then get referred through to secondary care and you see a consultant. Actually, there's an awful lot that can be done outside of consultant level in the community that's more convenient for the patient, that can be done by a lower grade member of staff, and we can get further up in the pathway and do more preventative work. All of those things can save money. The MSK scheme has been shown to save money, so it's schemes like that that we can then do in the community at a cheaper cost and hopefully better outcomes and more convenient.
Yeah, I mean, there is the reassurance. You're just not shifting the debt from the hospital to primary care.
That's where we need to be really, really joined up and part of the system recovery. The funding moves. So the bit about moving the debt, the way that the payment rules work at the moment is that if a patient in the past would have gone to the acute hospital and now we treat them in primary care or in the community, the trust doesn't get the funding for that patient anymore. And as a CCG, we've got that funding to fund a new service in the community. And that's, taking the MSK example, that's what we've done. The bit we need to be really, really joined up about is if we take the funding away from the trust, they still have their fixed costs, they still have their hospital there. So the bit about the joint recovery scheme is that actually we need to do the best decision for the NHS every time. So just looking at that whole picture.
Chair, I think that's a really important point. When we come back to system recovery, it's a jargonistic thing, but I think that point is very well made. The key, what I think some systems have done in the past is shift cost. And that doesn't solve the problem because one part of the system then you create an additional pressure. So we, as part of our system recovery, we are going back to some of the paradigms about community is best. So something about cost, quality, access. And some of the innovative work we're doing, certainly in Mid Yorkshire with the Trust, is actually thinking about the way that we organise and manage services between primary care, community care and secondary care, and we try and close down all of those contractual handoffs, which actually quite often get in the way of trying to do the right thing. The other jargon, I suppose, that's being used at the moment is threshold. So in other words, working with primary care and secondary care to agree when is the right time to refer somebody into a hospital to have a diagnostic test, to have something done before a decision is made to treat. And we're asking ourselves the question of, do we send too many people in too soon into hospital, which puts pressure on the hospital system, without doing something in the community? The key thing is that you look at how the money then works, because the last thing that we want in Mid Yorkshire is to pull millions of pounds out of Mid Yorkshire Hospital Trust to put additional pressure on the system. At the same time, we've got to, as commissioners, understand how we reduce our overall cost. So the answer is more conversations between clinical staff, more transparency in the way that we make decisions about when people, individuals, are then referred for a test or a treatment. So we are having that conversation now about understanding, when we make decisions, what is the long-term impact for finance and quality. So that's a really important point.
Can you, before I bring Councillor Ruller in, can you just clarify, please, that the work between the acute trust and the community services and the primary services that you mentioned there, is that happening in Wakefield or Kirklees or both? Can you just clarify? Because Wakefield do their community services different to Kirklees, and Calderdale do theirs different to Kirklees. So we just need to clarify that we are on a Kirklees footprint. Can you just quickly clarify that, please?
Yes, thank you, Chair. So just for clarification, and this is back to the complexity. So in the Mid-Yorkshire footprint, from a North Kirklees perspective, the community services are provided by a different provider than that in Wakefield. So Wakefield community services are part of Mid-Yorkshire Hospital Trust service provision. In Kirklees, it's primarily through Locala. However, we have the principles are the same about how can we integrate primary care and community care in such a way that we have sensible pathways between the major hospital providers. And I think that's where, Chair, some of the challenges about what historically some of our structures have been. And the reason that we're starting to talk on system is to look at the bigger picture. So I'll speak for Martin for a moment. So from a Mid-Yorkshire Trust lens, there is a conversation that's required with Locala, with GPs in North Kirklees, with GPs in Wakefield. Part of the role that I have, for example, is to try and join up those conversations across the Kirklees footprint from a Mid-Yorkshire system perspective. I hope that's helpful, Chair.
Yeah, thank you, Chair. I think the joined-up working should have actually happened maybe a little bit earlier and a bit sooner, but I just want a little bit of clarity under 3.2 and the 4 areas that you've picked out. With healthcare needs and people's demands changing all the time and their medical needs changing, how do you envisage reducing demand, the second point? Can you give me an example of what reducing a demand is?
Yeah, so part of this is reducing demand to healthcare services, full stop. And that can be around things like self-care. That's when we've got things like health promotion. How do we give people the right support so that they can be cared for in their own home? I know the example of my own father. My mother was able to care for him at home where he wanted to stay because they got great support from their community services, from the local hospice and others, and that meant, my dad could be cared for at home. If that support wasn't given, he would have been into hospital. So that, all different ways like that to actually reduce overall demand for our health system. And then there are different parts of the system where we just think care it would be better done at a different place, so we can reduce demand into the acute system by making sure that we've got primary and community services that are doing the right thing at the right time. So just a couple of examples. And then Pat, if you want to add to that.
Just briefly, so reducing demand, so in non-elective activity, it's understanding the support that we can give to most of the people who live with what is known as long-term conditions, so with chronic asthma, with diabetes, with heart disease, where the vast majority of those people will live at home with the right support, particularly through primary care, through their GP, through community services. What we were looking to do is to, particularly this time of the year, where we see an increase in acute admissions, we've seen a lot of people admitted with respiratory disease at the moment. And what we're looking to do is how many of those individuals with earlier intervention, with better support at home, could we deflect from the acute hospital? Clearly, if their level of illness requires an emergency admission, we do that. The other thing to do is, in terms of demand, it's if people do require hospital admission, that we actually get them back home as soon as possible. So demand on hospital services is also about how long people stay in hospital. So part of the challenge for us, particularly with the more frail and elderly even, sorry, Chair, is to understand the pressure on hospital beds when we're seeing people's length of stay going up. That has a knock-on effect in terms of the amount of people who are waiting for admission. So that's the non-elective end. I think I've touched on the elective end, which is about understanding how we can manage demand. That's not to say that people don't need an intervention, but more and more that we work with health and social care, and I think we actually have worked with health and social care over the last few years to understand the amount of support that people need that isn't health related, quite often is related to housing, people who live on their own, people who require some support, but doesn't mean that they require the support of the health service. I think the context now is that both the social care and the healthcare sector are both under significant pressure, and the need to work together is become more and more pressured, I think.
Did you want to come back?
Yeah, just...
I want to bring Amanda in.
Sorry, what was that, Liz?
I want to bring Amanda in a minute.
Okay, thank you for that answer. I think everybody would absolutely agree that care in your home and in your own bed and in your own surroundings it can only be a positive thing. But the reduction in demand that you've mentioned would only be a very, very small proportion of that in terms of before somebody actually needing medical treatment or in hospital. They would have to go. There's only so much that you can do within the community, and there's so much holistic approach that you can use before somebody actually needs medical attention. And I think that the numbers in the demands would be so small, because obviously if we're talking about care in the community and things like that, there needs to be something set up. There needs to be some sort of adequate funding to allow community sort of like care. And then it's just a point that I'd like to make. Thank you.
I think talking about care closer to home as well, aren't we, in this, in that you said that the changes in Mid Yorkshire have happened. Now, they've only just happened, I appreciate that. But part of that transformation was predicated on care closer to home, taking a lot of the demand. And obviously, from what you've said, the care closer to home doesn't look as if it's taking that demand at this moment in time. But before you answer that, maybe Amanda, from a social care perspective, maybe you could give me the financial situation is in relation to social care. Do you want to say what the position is in finances in social care at this moment in time?
There we go, sorry for that. Okay. So, Councillor Smage asked me if I would just provide a high-level update around adult social care. So this year we're reporting a 2.8 million in year pressure across adult services. And we're very mindful that this is going to be impacted on now by the additional winter spend that we're currently tracking. It's worth noting that this is a pressure that's felt at very local level, and it's carried as a risk into future budgets and years. Going into 2018 and 19, we are anticipating an additional £2 million of pressure that's associated with demographic growth, and that particularly is with regards to learning disabilities, where we know there's a number of people who'll be coming through transition that will impact greatly on the commitments there. And also price uplifts, particularly with domiciliary care, where we've retendered this financial year and provided us a significant uplift to manage that market. So that would bring our pressure going into next year to in the region of £5 million. In addition to this, we are working to deliver £2 million of savings that were agreed as part of the medium-term financial plan. So overall, we're going into 2018-19 with a £7 million cost pressure.
On page 17, you've indicated that the system will not achieve the financial balance in 2017 and 18. So, given the demands that you've identified in 3.2, the demands are obviously higher than what you can meet, and some of the needs are quite complex health needs, particularly of elderly. How are you expecting to meet those demands? Where are you intending on using reserves, or how? Can you explain how you're going to balance books?
Yeah, for CCG funding, a private company, if in the end it can't balance the books, it then goes bust and it runs out of cash. We're in a fortunate position within the NHS that in the end, in that situation, it shows as a deficit for us as CCGs and shows deficit for the trust, and we will get cash support from national government. So in the end, for 17-18, the way it's balanced is that if we overspend, which we will locally, then either other parts of the NHS in other parts of the country, or nationally, NHS England or the Department of Health will have to find savings elsewhere to offset our overspend. And that's why we come under increasing intense pressure from our regulators to say, you can't spend other people's money, you need to get back to balance. But in year, the way that gets balanced off is it's balanced off nationally by national government.
So are you saying that locally our services won't be affected if we go into deficit?
Yeah. So if we're in deficit in 17-18, which we will be, and the paper's clear in that, and equally, given the scale, particularly of North Kirklees' deficit, that's going to stay in 18-19 to an extent as well. We're required by our regulator, we're required to get back to balance. We will agree a plan with our regulator, NHS England, and they will want to see those schemes that get us back to balance over the quickest time frame possible. So the effect on local services will be the agreed plan with NHS England to save the money to get us back to balance. But what won't happen is we're not forced to do drastic cuts in 17-18 in that we must get back to balance in 17-18. We know we can't do that, and we know patient safety and quality wouldn't enable us to do that this year. So we will agree a longer period of time with national government, with NHS England, to do that in a safe way as best as possible. But in the end, that we will be required to take that money out and get back to balance in the best way that we possibly can.
Yeah, just wanted to pick up on the issue of the increase in agency staff that you mentioned. Presumably part of that problem is a reduction in staff over the last several years with trust needing to make roughly 5% savings each year. Just wondered, how do you see the problem being tackled over the next few years in terms of the aim to try and reduce the amount of agency staff that are used?
Thank you. The root cause is not actually reducing the number of staff, because I'm not aware of any trust in the country that has done that. The root cause is that following the mid-staff's inquiry, the number of nurses in particular required has gone up faster than increasing the number of nurse placements at university that up until September just gone were funded by the NHS. So in the country, I think the vacancy rate for Band 5 nurses, which is the entry level, is now about 12, 13, 14%. In Yorkshire and Humber, it's about 20%. And that is one driver. The second driver is what's going on with junior medical staffing. And the number of junior medical staff, particularly in the north, is less than the number of junior medical staff required to fill the rotas and all of that type of thing. And there's also an increasing number of doctors at the end of year 2 of their training who are choosing to take at least a year out, if not more than a year out of their training. So we have 230 vacancies for registered nurses, and we have about 100 vacancies for medical staff. Now, with medical staff, there is the ability to fill most, but not all, of the slots through agency. But through nursing staff, there aren't even enough nurses registered with agencies to fill the vacant shifts on the rota. And I think all of that is exacerbated, particularly for doctors, by the reputation of Mid-Yorks of being a pretty tough place to work because it is busy and understaffed.
Discretionary spending. Just wanted to find out what you class as discretionary and what have you looked at and how much money is there.
I mean, for us in the main, it is reviewing all of the non-pay requisitions and requests before they are proceeded with. And because we've got 2 PFI hospitals, they can be quite expensive. You know, even to put a notice board up can be quite expensive, let alone anything else. So they are the types of things that we have either slowed down or stopped altogether until the next financial year, just to make sure that we're only authorising absolutely essential things for the rest of this financial year.
So, I mean, picking up notice boards informing patients of things that are happening or things that are changing. If you're taking them off, how are you obviously letting the patients or letting the users know what's going on? What other adaptations or what other things are you doing instead of doing that? Because in a way, if simply just for, you know, making those changes on notice boards, and I'm sure we've all noticed things have changed in hospitals, yes, they have decreased in terms of basic staff. how are you having that communication with the average user, what's happening and what kind of costs, what savings have you made by doing so?
It's very hard to identify how much we've saved by doing this because it's hard to prove a negative in terms of slowing down the rate of expenditure. My guess is it's probably saved about £250,000 throughout the financial year. And the communication we have, of course, is with the manager that's placed the requisition for the non-pay item in the first place. It isn't with patients or service users.
But I think coming back to communication, it's quite a good point actually, because you do have notice boards. When I mystery shop acute trusts, I do read your notice boards. And in actual fact, communication is quite an important point for people who use various facilities, both GPs and acute trusts, in that things that are there to be used to communicate are not necessarily being used to the extent that they could be to help people understand what services, etc., are there for them. So, communication, I think, is a key point. But did you want to come in on the finance side of things?
Well, only because I think the discretionary spend bit was also under the North Kirklees CCG bit, and that's something that we put in a month ago. Really towards year end, we've had to agree a financial figure with our regulator. We need to make sure that we leave no stone unturned, and literally each week, myself as Chief Finance Officer, but also our Director of Nursing, to ensure we have a quality view as well. Each week we said to all of our managers, if we're not legally or contractually committed to something, they need to go through an extra process with myself and the Director of Nursing to safeguard quality, to say, do we really need to spend that this year? And the sorts of things we've looked at is filling staff posts, and the CCG, this is largely admin and management posts. Do we have to fill them this year? Actually, could we wait until April? People going on training schemes, things like that. So it's tended to be that type of spend within the CCG, because all of our funding of clinical services is already committed to for the year. So it's that type of thing that we've reviewed and looked at.
Just a quick question that I don't really expect you to answer, really, but you don't make any mention, and it's important, obviously, what you've shown us, that your main financial players have given us a very good analysis of what is happening. We don't hear anything at all about organisations like GPs or Locala and about how they're performing financially.
Yeah, to be fair to Locala, we hadn't. There's almost like who comes today. So there's Locala, but equally, I was coming here this morning, I was thinking actually, South West Yorkshire Mental Health Trust are obviously providing services to Kirklees, and it's not I didn't invite them along. So it's where do we draw the boundary with the local authority on social care services? But certainly, very much know our GP members, we're a membership organisation, and I hear on a very regular basis the pressure around our GP services and really around long-term sustainability. And how much, are we putting enough funding into our GP services? They're really struggling around workforce and struggling around coping with this winter. So I think it's a fair point, yeah.
Okay, just one final point from me. The hospitals and the CCGs are concentrated on their savings and their QIP savings and your system recovery plans, etc. And it sounds as if one side of Kirklees is looking at one footprint and another side of Kirklees is looking at another footprint, and presumably talking to different people in regulators and things like this. So, and we've got social care that's across Kirklees. You've got care closer to home that is supposed to be across Kirklees, that's supposed to be reducing demand for the acute trusts, which quite clearly is not doing at this moment in time. So how are you going to make sure that all these system recovery plans and your QIP savings, etc., that if you're looking at one side of Kirklees for one footprint and another side of Kirklees for another footprint, that what you're actually doing does not impact adversely on the other side to which the QIP or the recovery plan is, or that you create a situation where a service may be available for one set of Kirklees patients, but not necessarily for another set of Kirklees patients. How is the Kirklees provision being focused on amidst all these recovery plans, etc.?
Yeah, that's a really, really good point. I think where it's been helped over the last 6 months is the focus around the integration of health and social care within Kirklees. So the two CCGs, North Kirklees and Great Hospital CCGs, are integrating and coming together. A good example is I'm now CFO across both, interim at the moment in North Kirklees. So for the first time now, I see both recovery plans on the two systems. Equally, go back 6 months, two CCGs independently commissioned from Locala for community services. Having now sat across both, I can see that sometimes we ask Locala to do different things. We are now commissioning once from Locala for community services. It's a requirement from NHS England for North Kirklees, given our deficit in North Kirklees, that we appoint a turnaround director. In the past, North Kirklees have had their own turnaround director. Going forwards, we're going to make sure there is one across both CCGs. So I think we'll continue to have that complexity and that problem. I think inevitably when we talk to Mid Yorkshire patch and we talk to the CHFT patch, things aren't always exactly the same. But I do think now there's a joint team on behalf of Kirklees from the CCG perspective where we can get rid of a lot of those differences, and where there are differences, hopefully we see them because there's good reasons why they have to be different. So I genuinely see it as more joined up now than it's ever been before, and we've got a project leading around integration.
Is that joined upness happening at the acute side of things? It's starting at the CCG and the council level with the integration, but is it happening at the acute level as well, or is the acutes, because presumably you have different regulators, because one's a foundation trust and one isn't. So do you have slightly different needs from regulators for each acute trust?
Yeah, not really. Since NHS Improvement, brought together the Trust Development Authority and Monitor, there are technical differences, but in reality there aren't any. Both of us are on having to have frequent conversations with our regulator about both missing our control totals, etc. So it feels very similar.
Just, if you want to use the microphone, big bump.
My name's Kirsty Altrow. Massive apologies for being late. I'm Deputy Director of Finance at CHFT, and to support that, we have been working together more than I've ever seen in the past across West Yorkshire with the acute trusts through what we call the West Yorkshire Association of Acute Trusts, which looks at working collaboratively and making sure that we are doing the same things and sharing good practice and good ideas. So I think there is more shared working than there has been in the past, less competitive.
Yeah, I think it was looking more for the Kirklees voice in all of this. Yes, you are at the West Yorkshire Acute Trusts because you are meeting together. You're not meeting in public and the documents are not in public, but you are meeting together, yes. Okay, so we'll draw this item to a close if that's okay with everybody. Yes. Now, the next item is wheelchair services in Kirklees. But you've got people here on the winter pressures as well, have you? You've got people staying for the winter pressures? Who's dealing with winter pressures? Winter pressures.
So I think someone's coming from CHFT, I think it's Helen Barker for winter pressures, and Vicky's here for wheelchairs, and Martin, and I'll stay as well throughout.
So we'll do wheelchairs then next, as we're not all here for winter pressures. Okay. I just didn't know whether it was worth. Right. Okay. Wheelchair services in Kirklees. Then we have a report from the CCG, and we have a report from Health Watch as well. So Rory, do you want to go first from Health Watch, and then we'll hear from the CCG, if that's okay? Yeah, thank you.
Hello, my name's Rory Dighton. I'm from Health Watch in Kirklees. With me is Karen Huntley, who is a complaints advocate from Calderdale Health Watch as well. I'm just going to take 5 minutes to talk about our experiences and the stories that we've heard from people who have been using the wheelchair services provided by OpCare. So you've got the slides in front of you. We should have been telling a story this morning, but unfortunately Claire, who was going to tell that story, has the flu, so I'm not going to tell that. But all the way through the work that we've been doing, there are stories. In particular, there's in the documents that you have, there are the follow-up calls that we did with a number of patients in December 2017, which is really 50 stories that are up to date and very, very current. I'm going to quickly run through the timeline of what we've done, give you our perspective, and then talk through your supporting documents. But I really am only going to talk for 5 minutes or so. We started working on wheelchair services in about October, November 2016. Karen started collecting some of those stories then. And we heard 4 or 5 stories at that time that we took to the CCGs. And the response that we had at the time was that OpCare had a well-established service user group, but we carried on hearing stories, and over the next 4 or 5 months spoke to just over 90 people, spoke to people, to their carers. We spoke at forums, we went and listened at carers groups, and we spent that time collecting those stories and putting together a report which went to the CCGs, and you have a copy of that report in your papers. That went to the CCGs and OpCare in May 2017. Throughout 2017, we heard a continued escalation in the numbers of stories and also the extent of the waiting times and the concern expressed through that period. And I think all sorts of people have heard those stories as well. We then worked in partnership with the 2 CCGs and OpCare to do a revised version of the original survey that we'd taken out, and we sets of about 4,000 surveys went out through OpCare with Health Watch branding on it for a really comprehensive survey of people's experiences. And I think that the panel have had a draft copy of that report back, but sort of talk about that very quickly. The key themes, and just 5 key themes from our initial work. A theme about assessments and reassessments, and that OpCare isn't routinely offering assessments to children and young people, putting the onus on the families, meaning that when people come to be reassessed or asked to be reassessed, the waiting times for reassessment and the amount of time that children and young people, young adults especially, are waiting for reassessment is unacceptably long. And that theme there about long waiting times for service users to be assessed was one of the strongest themes that we had. Significant numbers of people were unhappy with the repairs service as provided by OpCare, and also communication, just poor communication through the service whilst waiting for repairs or assessment or for delivery. Communication that came through the service was really, really poor. And significant numbers of stories about the equipment not being fit for purpose as well. So those were the 5 key themes that we raised with CCGs and OpCare in May 2017. And then moving on to page 41, we did work in partnership to rework or to resurvey people and service users in autumn 2017. And the final draft of that report isn't out there, but we've had a look at the data and we've had a look at the draft report. And those themes very much come through that second piece of work there. So I think I'm comfortable with those themes. I'm also comfortable with the piece of engagement, second piece of engagement work the CCGs have done. I'm comfortable that we've independently verified that data, and the report, or the draft, as you've seen at this point, is a fair reflection. We also contacted 50 people who wanted to make further comments about the service, and those stories, again, you've got attached in your papers and represent the most up-to-date perspective from people and from service users of the OpCare service. The perspective that we wanted to make, and I wanted to make a comment on page 42 of your papers, is that there is a significant issue here with wheelchair services and with OpCare, and I think there are faults early on in our work here. I think we've been taking stories to CCGs to the CCGs and to OpCare for a significant amount of time. The stories around poor communication, poor standards of service, issues with repairs and unsuitable equipment should have been acted upon earlier, and more should have been done earlier. But we also want to make the point that this, and it follows very naturally from our conversation of the last 45 minutes, that this is about funding. The size of the waiting list with OpCare is about a lack of funding in the NHS and in our NHS and social care system at the time, and it's hard to criticise CCGs for that at a time where they're being asked and required by their regulators to make such significant cuts. It's really, really difficult for them to cut waiting lists for wheelchair services. And we just need a bit of honesty around that. I've said in here we need to be honest about that. And the question that I would flag back, or the question that I would ask us as a health and social care community, is whether we should be working in this way, or actually whether children who are long-term users of wheelchairs waiting for 30 weeks, on an average of 30 weeks, to be reassessed and to get their wheelchairs is really protecting the most vulnerable, and whether there is a need to look at the way that we spend money and allocate money. And I realise that it's enormously difficult for the CCGs to do that in this funding environment, but I wonder whether there's a question there about priorities that we need to be asking. And that's my introduction. Thank you.
Does the CCG want to say anything? Do you want to introduce yourselves? Thank you.
Yes, Chair. I'll start off by way of introduction. My name is Martin Percy. I'm the Head of Contracting for Greater Huddersfield and Calderdale CCGs. What we've sought to do is to provide the committee with the brutally honest truth in terms of how the contract is performing. We have included in the paper that we've submitted to the committee as much detail as we've got, and we've not tried to massage the figures. The waiting times are as described there. What I've also tried to do is provide a bit of background and context in terms of when the contract was originally let through a procurement. It was on the back of a really bad experience for patients, and there is a degree of frustration within the CCGs, those that have been involved in the service from that point, that we saw a reduction in the level of service we were able to achieve in year one in terms of turning the service round to the position that we see now. What you will see as part of the papers is the issue around funding has been there from the outset of the contract, in that we identified early on that there was a requirement to address a backlog, and that identified a particular sum of money that was to be invested at the start of the contract. From a Greater Huddersfield North Kirklees perspective, because of the financial position at that time, that had to be split over the 3 years of the initial term of the contract. So even at that point, there was an appreciation that the financial envelope was tight. At that time, the increased identification of the backlog was funded, or the reduction of that was funded by Calderdale on the basis that they were able to make that investment in year one. So all through, you'll see from the narrative all the way through the 3 years of the contract, now that we're into the 4th year of the contract, we have sought to manage the performance indicators and the provision of service within that envelope, and it's been extremely tight. And what we've had over that period of time is quite a positive relationship with OpCare, in that appreciating their issues in terms of the unexpected change in the demand that they originally tendered for, and the fact that we've had to work with them to see how we could mitigate the poor performance in the service over that time. I think, is there anything?
It's Vicky Dutchman. I'm Head of Strategic Planning for Greater Huddersfield, CCG. On behalf of the 3 CCGs, so that's North Kirklees, Greater Huddersfield and Calderdale, what we have been doing is looking at what we want to re-procure as a service at the end of this final year of the contract. In doing that piece of work, we've obviously taken into account everything that we've seen in the performance, the waiting list going forward. What we did originally is we requested some non-recurrent funding to help ensure that the waiting list didn't grow for the remaining 6 months of the current financial year. And I think we've included in the pack figures that show not only has it not grown any further, but we have managed to start to address it and bring it back down slightly. The work that is ongoing currently to support the current business planning round that we're in with all the CCGs is looking at 2 specific areas. So the first of those is looking at what we need to do for the remainder of this contract that we have in place, so that is up to October of 2018. And in looking at that, we're looking at a number of areas, of which we've got representatives from OpCare on a steering group with us, Claire, who Rory's already mentioned, and a colleague take it in turns on coming to the steering group and the board with us. But what we're looking at there is, what can we do to start addressing the waiting list, to get the waiting list down to about 8 weeks maximum, if at all possible, by the end of the contract value. And that's recognising 2 things. One, we want to get it down because it's the right thing to do for everybody. And the second one is, when we re-tender this contract, what we don't want to do is to be starting with a new contract that already has a great big backlog that also needs clearing at the same time. We need a good level playing field to try and sustain going forward. Within that, what we're also looking at is the range of equipment that is available on that, and actually, is that the best equipment for people to be using? So can we consolidate some of the equipment so that it meets needs, but without as much variety, because obviously the more variety you've got, the more that you're paying different suppliers. The second big piece of work that we're also doing is looking at what the sustainable new contract will be going forward from October 18. So what would the specification of that contract be? What would be the equipment that would be included? What would be the access and waiting time standards and the KPIs that we would be monitoring? So that is the second big piece that's ongoing as well at this time. And both of those elements will be starting to come through the CCG's governance processes from the end of this month to take that forward.
Yeah. Excuse me. Thank you. Firstly, Rory, Martin and Vicky, thank you very much for the report and in highlighting the issues that OpCare are going through and being honest about some of the issues that they've got and not dressing it up as something else. Firstly, thank you for that. I just want to make a comment in terms of the waiting lists and that. Yes, we know that they're high, and although I accept that some of it will, is money related and finance related, some of the comments that have been made in this report about OpCare don't really have anything to do with finance, more to do with poor communication in terms of not answering the phone. I'm not talking about repairs to wheelchairs or something that has a monetary value. I'm talking about somebody calling up and giving some feedback and nothing changing. And that's a communication skill which requires very little or no money at all. And secondly is whether it goes to retender or whatever, would it be worth having a conversation with whomever to say that this is our next 3 years or 4 years, and this is what it looks like financially, and these are the things that we'd expect. And actually, I don't know how it works, but would it be worth putting things in place that we expect this, this and this? Because the retendering, the next 3 years are probably going to be more difficult than the last 3 years, and it's really important that we're all honest to say that this is what we would like delivering.
Yeah, I mean, the 2 points there. One is on the communication side and some of the actions that Opcare have taken. I think it's fair to say, and we've had these frank conversations with Opcare directly, as in we don't think they do themselves any favours sometimes in terms of the way in which they've either been reported to communicate with service users, or some of the basic administration functions that you'd expect. And the frustration is that we're there before, you know, so it's more around maintaining a consistency of approach rather than the fact that they don't do anything. But definitely communication has been an issue, and I do know that there's been a change of senior personnel attached to the contract, and we have seen almost an immediate improvement in their approach to some of those operational sort of day-to-day issues. In terms of the retendering, you're right. I mean, what happened with this contract, based on all the information that we had at the time, that was not just gathered by the CCG, it was actually gathered by one of the commissioning support units to do an independent piece of work to identify what the requirement was for the tender. Based on that, the tender went out with, I think it was 1,900. It's in the paper. And then subsequent to that, we found that the actual demand that was uncovered is probably around the best part of 3,000 cases a year. Now, the difference in that was fundamentally down to we didn't know what we didn't know. We had information that said this is what the demand is, and therefore this is the financial envelope. And at that point, there was nothing to suggest. The first inkling was the change in the backlog position in terms of it was higher than we thought it was. What we wouldn't do is repeat the same problem. I think over the last 3 years, I think what has been a positive is that instead of it being just one big pot of money that was sat with the previous provider, what we've been able to do is get the analysis by CCG, by service user type, by complexity, that then helps us inform what we do going forward. That was absent when we originally tendered this. So some of it's a recognition of where we were, but actually going forward 3 years, then there has to be that honest conversation around, well, if the financial envelope doesn't change, because you know the session we had before that sort of paints that sort of picture, then what is it we need to provide? What do we need to focus on? What do we need to prioritise on? Is it the routine provision of a standard wheelchair, or is it the higher end, you know, the sort of children's complex seating? And those are the discussions that we're currently having in terms of developing the service spec and priorities for next contract.
Thank you, Martin. Exactly what I wanted to hear. Well done.
Work. Rory, you want to come in on this point, and then I'll bring David in.
Yeah, just interested in the size of the new contract and actually whether we are talking about commissioning a service that is significantly different to the one that we've got now, and with a reduced scope and reduced access to services for some of the most vulnerable people in our community. And whilst I absolutely accept that your financial pressures are great, then as again a health and social care system, protecting the needs of the most vulnerable and enabling some of the most vulnerable people in our community should be a priority for us. And so I would be nervous about rationing and cutting access to wheelchair services in a new specification. I wonder what your thoughts were.
Yeah, I suppose a bit of a personal reflection, because I've been involved in wheelchairs since we started this, I think, and it sort of presses my button because I knew how bad the service was before. I think, to answer your point, we haven't, within the CCG, there's Ian has alluded to, there's a lot of competing demand in terms of, well, if you spend money on this and you don't spend it on something else. And I think over certainly the last 12 months, I think there has been a lobby within the CCG to say, well, you know, we need to look at wheelchairs and what the envelope is. And that has been weighed up with all the other competing priorities within Calderdale, North Kirklees and Greater Huddersfield. I think it's fair to say in Kirklees there was a recognition of the pressure in the contract, hence the non-recurrent money that allowed us to address some of the waiting list issues with the start of the fourth year from October last year. That wasn't the same reception we got in Calderdale, so the pressures and the competing pressures and priorities are different depending which CCG there is. I think in terms of I don't think we're not coming from the perspective that we want to make things worse for people. I think it's more about a conversation about, well, are the thresholds appropriate? And it's having a conversation about that, and are they the same as everybody else's? Are we outliers? Because we've got a contract that essentially was spec'd best part of 4 years ago. So by definition, we would expect some change, but we're not seeking to make that, at the expense of the service that we provide to the vulnerable.
Okay, I think I've had a couple of people waiting to ask questions. If you have got a amount for the contract, if people are waiting for a long period of time for a wheelchair, and then if it's a young person, for instance, is it still suitable when it arrives? Or if it's somebody with complex care needs, have those complex care needs changed by the time the waiting list has been reached to the end? If that can be resolved, then surely the amount of finance that's needed, because you're having to either change a chair because it's wrong when it comes, it doesn't allow for independence, etc., and that the chair only lasts a short length of time rather than a longer length of time, you're actually in this, it seems to be creating more demand than it actually seems to be dealing with. Are the CCGs looking at how that can be resolved, please?
Yes, so within the work that we're doing, and when we're talking about we're looking at the different types of equipment, one of the things, as an example, that we've looked at is if you've got 3 levels of chairs and people's needs change, actually, if at the pace people's needs change, if we focus on buying the higher spec because it does last longer, it meets more people's needs over a longer pace of time, does that fit our financial envelope better? Yes, that is the type of work that we're looking for. What we're also looking at is in the proposals that will be coming back in for consideration, there will be a range of options. So there will be an option saying if the financial envelope that we are working to has to remain the same as it currently is, what does that mean in terms of a specification and how we put a threshold in for the types of equipment and who gets that equipment and the waiting list. Equally, if we could deal with the demand in its entirety, what would that actually cost us so that that can be fully considered in the rounds for that priority setting? So that is the work that we're going to be doing.
Yes, bearing in mind the financial position which we've considered and where we were coming from in terms of how the contract operated previously, so accepting that, the report, including the Health Watch report, pick up on a number of specific cases where there are difficulties. There's also reference to the number of complaints received via OpCare. Although interestingly, there's nothing about the outcomes of those, whether those have been resolved, whether any lessons have been learned, whether there are any common issues that have been picked up through the complaints. So it's really about, I suppose, it's a contract monitoring point, really. Given that these problems are emerging, I wonder what the CCG has been able to do in terms of requiring the contractor to put some of these problems right.
Yeah, from a contract management perspective and contract monitoring perspective, we are pretty close to OpCare in that I have one of my members of staff, although it's in theoretical terms it's a small proportion of her portfolio. She spends most of her time on wheelchairs, I think. There are two things. There is the constant monitoring and the challenge in terms of performance issues that are dealt with through the normal contract management group process, and then there are responding to individual issues as they occur, and from that any trend analysis would be taken through the contract management process. And I think I would say that OpCare are fully aware of our frustrations when they do get it wrong, but we're also conscious of the pressure that OpCare are operating under.
I appreciate that, but I think some of the issues raised are not primarily financially related. They're issues about how the service is provided and responses to lack of information, that kind of thing. They don't necessarily have a financial implication. It's more an issue of quality of service. And just on that point, I'm not sure whether OpCare would be inspected by CQC. If not, is there a quality audit of the performance of organisations like OpCare providing wheelchair services?
Yes, I mean, with all contracts, then there are essentially two tracks. You've got a finance performance track, and then you've got a quality and safety track. And the issues that are around patient experience, patient safety, and overall quality of service would be something that goes within the CCG's Quality and Safety Committee for review. And it's been there, I think, a couple of times over the last 12 months. Primarily, I think some of the work that Healthwatch have done to draw out some of the key themes around the issues that OpCare have. And when I was talking about the contract monitoring bit, it doesn't just include, well, you know, how much money have you spent now? It's across the whole gamut of, you know, what the quality indicators, and you've got a dip in performance around this. You know, why is there a dip in repair performance? So all that is covered as part of the contract management process. But then within the internal CCG governance process, then it both goes to finance of performance and quality. Any escalation required would then go to back into us to take up with OpCare. So if quality raised any issues, then we would go back and discuss that.
Just one final point. And is there some kind of independent quality assessment through a body like CQC, or?
I'm not sure they're covered by CQC, but I'll take that back and find out. So.
Just on that, I don't believe they are covered by CQC, but what there is on an annual basis, there is a national survey and audit of wheelchair services, of which OpCare did participate. So we do get some benchmarking information back on that.
Okay. The fact that they need to actually get the assessment right in the first place, a lot of this seems to be getting it right when they go for an assessment, and also the communication. That is about actually quality of the care that is being provided by the service provider, isn't it? It's not about finance, it's about quality and communication, isn't it? Because, you know, if you do the assessment correctly, surely you are looking to see whether those assessments are being done correctly.
I hope I've not given the impression this is all about the money. Some of the issues arise from the fixed financial outlook, but we don't just look at the money.
Now, Councillor Whittaker from Calderdale is here to listen to this item, and you'd like to ask a question, I think. It's the large button on the console for the microphone, okay?
Yeah, thank you. I'll just quickly add on that to my introduction. I'm a Rastrick councillor for Calderdale, and this item is actually coming up in Calderdale in a couple of weeks, I think, so we'll be looking at it ourselves then. I think a lot of my points I wanted to make have been covered, much about the quality and the communication of the service of OpCare. The communication, I mean, I've had problems myself dealing with cases as a councillor, trying to deal with OpCare, so if I'm struggling, God knows how the service users are coping with it, with the lack of a communication and managing expectations as well, something that the Healthwatch report flags up. People would much rather know where they stand if they're going to be waiting 30 weeks, 30 odd weeks, as a potential, not as a definite, so they can make interim measures themselves if needs be. But people much prefer to know where they stand rather than just be left waiting and having to chase things all the time, constantly. Just to feed into the quality, I think the nature of the contract, the fixed fixed value contract, there doesn't seem to be any incentive for OpCare to provide the best quality service if they're getting a lump sum of money based on a forecasted amount of referrals that they are expected to get that year. And because the CCG have an ability to use discretionally, you know, to find them if they do find issues with the quality, but because it's deemed that there's not the performance deficiencies underweigh the nature of the demand, they aren't utilised. Understandably, I get in one sense, but then there is nothing to make them act or behave in a more quality kind of way towards service users. And as we can see, some of the things that have come up in the Health Watch report, 6% does not consider what is important for the wheelchair user, and 2% are not listened to. I mean, that's not, again, it's not an issue with finances. That's something that maybe it's a staffing issue, maybe it's the values and beliefs of the company or the industry, I'm not sure. But they're things that money can't really buy, really. It's the empathy and compassion that you need in these kind of services that are lacking here. Also, one issue that I find with the contract is that OpCare have the power to assess and to provide the equipment. Again, having a lump sum at the beginning of every year doesn't give them much incentive to do that in a quick way or in a particularly the most efficient way that they can do. Also, one of the cases that I've been dealing with, he waited a year for his wheelchair.
We not going into specific cases because the CCG can't answer specific cases.
No, okay. I'm using it as an example. Okay. A case that I was dealing with was waiting a year for a wheelchair, but in the interim he was so desperate, his work colleagues clubbed together for a wheelchair. But in having done that, he was then treated as a re-referral because he was no longer initially waiting for a wheelchair, which made his waiting time a lot longer, being a re-referral rather than an initial or new referral. So I just wanted to make that point. Thank you.
Whittaker. Sharon, did you want to come in? Yeah. And then...
Could you just tell me where OpCare's based? Is it a local company?
No, I think they're based... Their head office is in Oxford, I think.
Yeah.
But they are, in terms of provision of service, they are based locally to provide service.
But when people ring, do they ring locally? Or do they ring to Oxford and it's a call centre situation?
No, they ring locally.
So when they ring, they definitely ring local. Yeah. And the people there who are dealing with them, are they all trained or are they just people who take messages and pass on to others?
No, they're trained.
Because there seems to be a staffing issue, I think, because it's not all about money, as you say.
No, and the thing to bear in mind is that a proportion of those people are ones that were providing the service before, so they were trooping across as part of the service transfer. So, and OpCare will deliver customer service training as we do expect them to do. So, I think there is an issue about how effective some of that is, and we continually take it up, but we'll redouble that when we come out of here. I think we're already working on the emerging themes from the Health Watch, and clearly communication and making sure that your front-facing staff do what they're expected to do every time, I think is one of the issues we'll take back, because I take the point that if you're poorly dealt with at the outset of your journey, then it doesn't, it's unlikely to improve, isn't it? So I think we'll take that back, certainly.
Can you address the point on incentivising the contract? But also, in that, can you also talk about the waiting list system? Because it appears from the waiting list system that you move between waiting lists. So you may have achieved so many weeks at one point in the process, but then you go on to another waiting list and you have a further set of weeks on that. And is the way that the performance that is being monitored by the CCG actually incentivising the outcome at the end, which is a wheelchair that is suitable for purpose in a particular time frame, or is it just a case of moving between waiting lists? There's 2 points there, the incentivising of contracts and the waiting list system, which does seem to be rather a problem.
In terms of incentivisation in the contract, or the potentially for perverse incentives, I think from our experience, then we don't think that's the case, given that they are providing the volume of chairs that is required. The issue is around the weight of that, but in terms of the number of pieces of equipment being provided during the year, then that is consistent with, you know, the 53% increase on what was originally intended. So it's not that they're not providing the kit. In terms of the specification of the kit, I think there is a question to be asked as whether or not that continues to be suitable, because the specification for the kit, depending on the complexity of the individual, was set as part of the specification. So that the deviation from that is monitoring. I think there's an interesting point around fitness for purpose and that, because clearly when we've challenged Opcare with that, they are quite adamant that both the assessment and the provision of equipment is appropriate for the functional needs of the service user. In terms of the waiting list, I think it's true. It's like any other, well, it's like most of the health service processes, that you've got the initial wait to, you submit your requisition or your prescription. You've then got to wait to get into a clinic to get the assessment. You then get the assessment, and then the wait for the identification of the kit that needs to be ordered, and then the delay in ordering the kit and then providing the kit. And you're right, I think people will move along that pathway, some quicker than others. So a prescription that results in a standard chair, which is essentially a stock chair, will be, you know, within 14 weeks or something like that. So, and then it's the complexity that adds to the...
Yeah, and it seems to be the people with more complex needs that are waiting the longest, and possibly the ones that will have impact on their health and well-being more because they're not independent, etc. But also actually the impact on the rest of the system as well. So if somebody's got an incompatible chair, the actual impact on the primary care, the secondary care, the social care, etc. There's a wider impact in the system for this as well, that presumably needs to be looked at. Rory, you wanting to come in? You've been waving at me for a while, I know.
Well, I'm just waving at you, Councillor Sway. Very much to follow up on that point, that we've heard stories from people who've ended up in CHFT hospitalised because of poor fitting and ill-fitting wheelchair services. So there's a point there about the unintended consequences of having one part of the system not delivering. And a second point, just following up on Dave Rigby's point, the numbers of stories that we heard about this service would have led us to escalate to the CQC for any other provider, and we were unable to do that as an organisation because Opcare aren't a CQC regulated organisation. Had the contract been with CHFT, for example, we would have found a way of escalating that issue back in and putting the spotlight on that organisation. So there's something there about the layer of quality control protection that patients get by contracting out with private suppliers, and also a point about the way that, you know, our whole system is moving towards a more joined up system where the consequences of X are felt in different parts of the system, and that's to be welcomed. This is an example of an organisation that I think is working independently and perhaps doesn't join up with the rest of the system as well as it could do.
Actually, coming on from what Rory's just said, the current contract finishes in October, 10 months from now. Reading the report and seeing what's happening as a councillor as well, it's worrying to see what's going to happen for the next 10 months. And I'm not satisfied, and I'm not happy with the fact that I don't think at the moment Opcare are actually making significant changes to not just, I mean, I know you can't reduce the waiting list itself, but in terms of satisfaction to patients, it's not there, and I can't see that changing. I know you say you've had those conversations and you seem to have a very positive relationship with them. However, it doesn't look like that's actually, there's a turnaround in there. I'm not convinced that that's going to make any changes in the next few months. So what can you say, what can you do to convince me that in the next 10 months we're going to see some change from them?
Well, I don't know if I can convince you, but in terms of what's happening, some of this is around timing. So we've just had the results back from the feedback survey, which is powerful in terms of the themes that are developing, and also almost that, you know, it takes you out of the argument saying, well, so-and-so says this, Opcare says something else. It's almost, well, forget about that. This is what, you know, demand perception, we'll take this as the reality and then work on that. So I do know that the intention is to sit down with Opcare and go through it, you know, and have a full and frank discussion with them as to where they are. I mean, from an Opcare perspective, I'm not here to talk to them, but I do know that they are sensitive around this contract because they see it as the biggest problem in their contract portfolio, in that it causes them quite a significant amount of reputational damage, which they don't get anywhere else. So.
Can I just come back on that one? The other bit, just to, and it's not to give you reassurance at all, isn't this? But just to tell you what we are doing is, communication has come up as the big one, and we've identified that as well. And as Martin said right at the beginning of this, there has been a change in the senior management of the local service through Opcare, and we're meeting with them regularly. And they are putting an improvement plan in place about the communication, because it's recognised by their senior managers as well that this is an area that you can gain strides on without money. So that is being taken forward.
Okay, thank you. Yeah, I just wanted to reinforce the point made by the councillor from Coaldale on paragraph 4.4, and that's given the fact that it is a fixed value contract, the decision not to use financial sanctions against the contractor, that is hamstringing the supervision of the contract in many ways. So in terms of the next contract, do you intend that to be fixed value? And in which case, how would you look at applying financial sanctions if that became necessary?
Quickly, yes, I think we would. 3.5 years down the line, I think we would have a different contract structure. It would probably be an incentive-based stretch, you know, so an element of the contract value will be set around stretch performance targets, which are then linked to performance payments. Clearly, there's a lot of work to work up that incentive scheme, but I don't think we wouldn't do what we did 4 years ago. And we've got experience of other incentive-type-based contracts that we'd probably use.
We're going to draw this to a close now, okay? If we could summarise then, I think we would want to know how you're going to use this feedback report to actually make serious changes for people, both within this current contract and going forward. Obviously, you've just got the feedback report, haven't you, in? So we would want to know that. We would also, I think, communication, a big improvement on communication. We would want to see that is improved. And quality monitoring, yes. That actually have some reassurance that the actual assessments, etc., are being done correctly. And also how you're addressing this waiting list, this moving between one set of waiting lists to another, to another, to another. That surely can be sorted out within this contract rather than waiting for another contract. And that information about the impact on the wider health and social care system, and how people's experiences are actually being taken seriously. So Opcare's service user group, is it representative of its service users and how it's going forward? And do you want to have Opcare? Yeah, Opcare. We would like to invite Opcare. as well. Okay, so there's some further work that I think we looked at. Do you want any? Is there anything else that councillors would like to, members of the committee would like to see? My apology. No. The Calderdale Scrutiny is got a discussion on this subject on the 7th of February at 6 p.m. and any Kirklees councillor will be welcome to go and join that discussion as well. Okay. All right, so we'll bring this item to an end, but we would like to see some change, and some change pretty quickly for people's experiences. Okay. All right, especially on the communication and the getting the chairs right first time. All right, okay. Right, we will move to winter pressures then while I still have some voice left. Okay, so anybody who is not here for winter pressures who wishes to go, please do so. Anybody who wants to move to the seats who have come late for winter pressures, then please do so. If we take the winter pressures first, we haven't talked much about social care. So does social care want to go first this time? And then we'll have the health as part of the whole thing. Okay, thank you.
Okay, so to introduce myself, which I neglected to do earlier, I'm Amanda Evans and I'm the Service Director in Adult Social Care. So an update from the social care's perspective around winter pressures. We did anticipate winter this year, and so Kirklees, we pulled together a winter plan around social care activity and what we were anticipating and the plans that we put in place. And the council ran a conference in October, which was a multi-agency conference looking at issues around winter preparedness and resilience. That was with our emergency planning colleagues. On the back of the winter plan, we took the opportunity to review our operating pressure escalation levels to make sure that since we've got new structures and new roles that everybody was cited on those and that we had sufficient escalation of contact details and cover of rotas, because we know that we will be expected to join calls at weekends as well as during the week. We also mentioned earlier that we've got a new domiciliary care contract. So one of the things we did ahead of winter there was to not formally transfer people between domiciliary care providers to make sure that we were keeping the disruption in the market to the minimum that we possibly could. And under development and in place are the initiatives that are detailed in the high impact change model, which is a national requirement to use in order to support patient flow. So it's fair to say at the minute that both hospitals are experiencing significant pressures and are operating at the escalation level 3, bordering on 4 at times. And we've been partners around the table in helping to resolve the day-to-day issues that we face in that. Broadly speaking, the hospital social work teams on both sites or on all sites are keeping up to speed with the assessments. We've taken some pragmatic actions to remove review activity away from the hospital teams to help them to concentrate and to keep on top of that increased demand. Residential placements are broadly available. The more problematic area for social care is the availability of nursing placements, and in particular those that specialise in dementia care. An ongoing pressure that we face through the year is the availability of domiciliary care in the communities. We have seen some improvement in capacity since our new contracts came into being on the 4th of December. But it's worth noting that reablement are still delivering 440 hours of domiciliary care. The A&E delivery boards, of which we form part, are keep under constant review the performance and quality metrics. That includes the 4-hour emergency standards in hospitals, unplanned emergency readmissions and delayed transfers of care. And I think it's fair to say that whilst performance had regressed over December, year to date remains above the previous year. Delayed transfers of care, we are working to a 6.5 variance in our target around DTOC, and that's a positive. We're overperforming in delayed transfers of care. But that's not to say that we want any delayed transfers of care, because very mindful of the pressures in the system. Other actions that we've taken is we've communicated with all providers, domiciliary care, particularly around getting people home for lunch, the timeliness of assessments, particularly with care homes coming into hospitals, and around evidencing where equipment deliveries and adaptations are required to support discharges, that they are prioritised, and there's been communications about that. We've taken some decisions around allocating work to domiciliary care providers off framework, and we've put a process in place to manage the risks associated with that. We've used our discretion around placements that are around above with our usual costs, and we're working with CQC around care homes that have suspensions in place to look at can we possibly work to a different level of risk in order to support the whole system. We've got a rolling recruitment programme with reablement to try and make sure that we retain as much capacity there, both to right size the care packages for the long term through promoting independence activity. We've had some quite recent discussions with our housing colleagues, and we're looking to utilise guest suites in extra care housing facilities in order to have discharge facilities there, and we're underway with plans. Mid Yorks have secured 15 residential care beds, which we're utilising as intermediate care capacity to help with the discharge to assess pathway. And we're working with CCG about doing similar in South Kirklees. So there's lots of activities now. I haven't gone into all the levels of detail, but that's hopefully you get a feeling that we're trying to be very pragmatic. We're trying to work as a whole system, and that includes our end supply chain, our independent sector providers, care home facilities as well. We're very mindful that at the end of this, we're going to have to, whilst the hospitals have to de-escalate any additional open beds, then we have to do likewise, because we have a lot of people who are now going to be placed in short-term placements and with interim arrangements that will require a second round of work to get them with the services that they need at the long term. And also there's a lot of costs associated with this activity, which we are working towards capturing, partly so that we can build it into our plans next year. At the end of this winter pressure period, we will, with partners, be capturing the learning from that so that we can build in particularly some of the things that have really helped into our formal plans, into our anticipated actions going forward next year.
Okay, thank you very much. Right, okay, we've had a report from the health side of things on winter pressures. Can I just say, first of all, thank you very much for coming when you're under a lot of pressure already to come here to talk about this and for providing the update. It was very useful indeed. So do you want to introduce anything on the, Martin, do you want to say anything? CHFT want to say anything? Who's going first?
I'm happy to kick off.
Right, okay.
In mid-Yorkshire, the winter pressures have caused us significant operational problems. The thing that has really made an impact, it appears that compared with the same period last year, the number of admissions has gone up by 8%, and one would normally assume there'd be a 2 to 3% year-on-year increase, so an 8% has caused us real difficulties. And those difficulties have resulted in us typically having 60 medical patients in surgical beds, and we've also got about 80 escalation beds open as well, both at Dewsbury Hospital and at Penderfields Hospital. The delays in getting people out of the A&E departments into a bed have led to, pretty significant overcrowding at Pinderfield's ED department. And, that's had a poor impact on patients. It's had a poor impact on staff in terms of working environment and them having to, their inability to provide the quality of care that they wish to do so and have been trained to do so. Despite all of that, the number of 4-hour breaches week on week is less than the same time last year. The reduction in the number of breaches at Dewsbury Hospital is very significant. So, for example, last week there were 104 breaches at Dewsbury. The same week last year there were 260 breaches at Dewsbury. So there's been a significant improvement year on year at Dewsbury Hospital. And indeed, when one looks at the year to date, the number of breaches at Dewsbury is half that it was this time last year. The number of attendances in the A&E departments have been broadly the same. So at Dewsbury last week, there was only a reduction of 100 out of a total of 1,600 attendances. And that is despite the centralisation of serious cases brought by ambulances into Pinderfield. So the volume of activity has only very marginally been affected at Dewsbury Hospital. In the last 10 days, we've been having about 20 people a day turn up with flu. We are cohorting flu patients on one ward at Pinderfields Hospital for patients with type B flu, and patients with type A flu are in single rooms on the wards at Pinderfields Hospital. The thing that's really impacted us negatively last week and this week is an outbreak of norovirus at Dewsbury Hospital. All but 2 wards are affected. It's had a massive impact on our ability to discharge patients and admit patients, and the knock-on effect at Pinderfields has been pretty significant. So that, members, is where we are at the moment.
Okay, thank you. So I'm Helen Barker, Chief Operating Officer for Colindale and Huddersfield Foundation Trust. I brought with me Dr. Rob Moisey, one of our consultants who's been certainly at the front line at the moment. So if there's anything clinical or medical, I'm going to ask Rob to speak. And I think we both came when we came to talk about the reconfiguration as well, so thought that would help in terms of a bit of continuity. So I think a bit of a similar picture. I think we had done lots of winter planning. I think what we found as we came out of the New Year period, we came out of there in a weaker position than we anticipated. I think normally you would see on the Christmas Eve couple of days before, Christmas Eve and the day before, you tend to get quite a high discharge rate. I think we probably hadn't, in hindsight, recognise actually that was a Saturday and Sunday, and therefore we weren't necessarily going to get the same discharge number, so we didn't go into the bank holiday period with quite as many empty beds, and there's an acuity, there's a case mix issue out there. So we came out of the New Year period in a difficult place. In particular, we'd had a very difficult New Year's Eve and New Year's Day, and we had 154 patients who waited longer than 4 hours through our A&E department on New Year's Day. And that's the single highest figure we've ever had. We came in on the Tuesday and really started to enact into a command and control. Weren't quite sure at that point how much of this was the post-bank holiday versus something different. I think where we got to on the Wednesday was we hadn't really made the inroads into some of our flow on the Tuesday that we'd anticipated. We thought we had enough capacity as we went into the night. And we actually had probably another 40 admissions overnight that weren't in any, we didn't anticipate through any of our modelling. We hadn't seen that level of admission before. So we came in on the Wednesday with a high number of patients in the accident and emergency department at Huddersfield. What I can say is they were all in a bed. So actually we had brought in some additional capacity. We'd moved patients whilst we couldn't put them in a ward area at that point. We had found quiet areas, not corridors. Technically, you could say they were corridor. They're a very wide corridor with doors at each side of them that we could make quiet areas. We put a nurse in there and we put patients on their beds so they were comfortable, they were hydrated and they were fed, etc. So we then went into full command and control from there. I've given you a couple of briefings, but some of the key issues that we did, we closed down all of our activity apart from cancer and time critical work. So we closed down all of our day case capacity in the main to provide nursing staff to cover. We had 96 additional beds open at one point. At the moment we're down to about 61 additional beds, so even with all of the work that's going on as a system, we're still in a higher level of escalation capacity than we can robustly staff for. And that's a key issue for us at the moment in terms of making sure that we've got adequate nursing and medical staff. We came out of the bulk of our routine outpatient capacity. And for our medical specialties, I think I'd probably say that's been one of the biggest benefits in terms of making sure that we've got consultants on the wards and we're getting a senior consultant review twice a day. So whilst we've put some of our day case capacity back in this week, recognising we've closed 30 of the escalation beds, we have retained some of the medical capacity and kept some of the outpatients at a lower number. We've had 67 confirmed flu cases since the 1st of January, so we still get others that we have to isolate until we've confirmed whether they're flu or not. And we have a single isolation ward at Calderdale, and we have isolation capacity at Huddersfield. We have seen the higher numbers at Calderdale, which is reflective of we've been able to cohort because we've done the cardiorespiratory change across there. We actually have got 4 patients who are on ICU, not necessarily on ICU because of flu, but they are on ICU and have flu as part of their condition, which is a bit of a pressure for us. We've been working with system partners on a daily basis. I think things are speeding up in terms of the ability for us as a system to enact some of the changes, but we've had to really push this week in terms of getting what I would regard as some step change into some additional capacity outside of the hospital so we can really start to feel the benefit. Our admission numbers have been up about 20%. Half of that is the attendance, the admission numbers from A&E attendances, and half of that is admission numbers from GP referrals, and it's about 10% up on each. So on 4 days last week, we saw 169 admissions, 195, 185 and 165, which is probably 30 to 40 admissions a day higher than we would normally see, and that concertina of those 4 days really was one of the pressure points for us across the system. We're working with partners at the moment. I think one of the things that we're currently moving to is quite a proactive discharge to assess, a bit like the model that's already been talked about. So we're just working to make sure that our patients know when they're admitted. They're actually, once we've got to the stage that they no longer require acute care, that we will be moving them into a community type provision to do that assessment. I think we need to be a bit, we've been very patient-focused around the choice agenda. I think our anxiety at the moment, we have got such a high proportion of sick patients who are coming in, and we need to just take a little bit of a harder line in terms of making sure the patients, that the place that we would move to for the discharge to assess is safe, and it's as appropriate, but actually we can't afford, from a critical nature of acutely unwell patients, to have patients waiting for that choice within an acute bed. So that is something that we're enacting this week, because whilst we have got partners coming up with additional capacity, we do need to make sure we're using all of the capacity across the system. I'm going to stop there because I have provided a couple of briefings down. I'm happy to take questions rather than a monologue, if that's okay.
Yeah, thanks for that. I just wondered, please, it's not blindingly obvious to the ordinary member of the public. What were the main reasons for the surge in A&E attendance?
So what we haven't seen is a high attendance number. We have seen the sickness level of the patients who are attending is particularly high. So on some days last week, we had over 50% of our patients who attended in A&E actually needed admitting. But actually, there is something around whatever's going on with the news and the publicity. I would say the actual attendance numbers are lower, but the acuity of the patients who are attending is significantly higher.
And why are they attending?
Rob Moisey, Consultant Clinical Director for Acute Medicine. I think we're seeing a changing population over time. We're seeing increasingly older patients, frailer patients, and their ability to cope with acute illness is significantly less. And I think, as Helen says, I think we're seeing a large number of particularly older people, frail people who are extremely poorly. And that might be a result of flu or superadded infection.
So it's really got nothing to do with the fact that GPs were closed for a protracted period over Christmas?
I think there's a number of factors. I don't think that particularly plays a large part. That's always been the case since as long as I can remember. I don't think that's changed in the last 20 years. And so what we're seeing now in terms of GP provision over the Christmas New Year period is I think actually, if anything, is better than it has been in the past. So no, I don't see that as a major part of this.
Sorry, can I just add, because I just to actually quantify that. So we have an ability to stream patients who do require primary care intervention. We can stream if they turn up at A&E. We've put additional capacity into that, or our CCG and local care direct colleagues have. And certainly on the Kirklees side of the system, there's been 2 GP hubs that have been open over weekends across the bank holiday period for both of them. So I would echo Rob. I think the provision is probably greater this year than it has been in previous years.
Sorry, I missed part of your brief at the beginning. You talked about admissions and the numbers of admissions, and if they're not requiring an acute bed, how many of them have come out in a readmission, so come back in within 24 hours or 36 hours and had to be readmitted for whatever reason? I'm just thinking perhaps of because of the criteria of what's going on in terms of the capacity that we don't really have and we don't have at the moment, not enough bed spaces, and it's a case of patients going and perhaps having to come back within 36 hours. Do you have any numbers in terms of that?
So I don't have any numbers, and I can certainly go back and have a look at that. What I can say is, so both ourselves, so our community division from a Calderdale perspective and the Locala team, actually part of this has been mobilising. We've got community district nurses, we've got the community matrons, we've got the specialist nurses are actually in reaching, and both teams have put additional capacity in to do everything we can actually to prevent a readmission and to keep patients at home. So we recognise we've probably been discharging patients who if we weren't at such pressure may have stayed a little bit longer, but we've done that in a very controlled way with additional capacity in the community on both sides. So I'm not personally getting any feedback that we've got a higher readmission rate than we would normally see. But I can go back and check that anyway.
Yeah, sorry, it's just because of some of the casework that we've received through the Christmas period. I've had an increase in constituents getting back when they've actually visited the hospital and family somebody else has, or somebody they know has visited the hospital but had to revisit and had become, for whatever, I'm not going to go into individual cases, but becomes quite seriously ill. And it's just a case of, has there been something that's been missed out, or what's that in terms of numbers? Thank you.
Martin, do you want to, from Mid Yorkshire's perspective, comment on readmissions?
No, I mean, we're very same as Helen has described.
You can let us have some information as well then.
Yeah, sure.
Okay. David.
Yes, a couple of questions. First one's for CHFT, and that's just on the postponement of elective procedures. It mentions that 22 of those were cancelled on the day of surgery. And I appreciate all the pressures that are around. I just wonder, in the future, is there anything that can be done to try and reduce that number a bit further?
That was just one day, so actually that was on the Wednesday when we came in, and we made a decision due to staffing and the fact that we had a lot of patients on beds in A&E. We cancelled the whole day case service for that day. So actually, because they're shorter procedures, they're high volume, so it was just that list. After that, we've everything's been done proactively and before that. And we were only planning to run day case and cancer and time critical in January anyway. We had already proactively cancelled the rest of our inpatient electives as per the guidance from the centre. So we tried to keep the inconvenience as low as possible.
Thanks. And the second question is in relation to adult social care. I think you mentioned the provision of additional residential care beds in Mid-Yorks, and I wasn't quite sure whether that was the trust that provided them or...
Yeah, it's provided through some additional winter pressures money that's been allocated to Mid-Yorks.
And is that a new kind of development? I've not come across that before.
It's, if you remember the Chancellor's budget statement, 300 and something million was allocated for winter pressures. Because Mid-Yorkshire is classed as a Category 3 area, unlike Corderdale and Huddersfield, who traditionally do better on the 4-hour standard, we received a higher than average amount of winter pressures funding. So we have made some available to Kirklees local authority to fund 15 beds, and we've done the same for Wakefield for 15 beds. And we've used some ourselves to fund all the extra capacity beds that we've opened as well. And what I should have said when I spoke as an introduction, for the record, the support and the way both Kirklees local authority working with us and Wakefield local authority are fantastic, so the pressures that we're under in one way is even more disconcerting because the system as a whole is working much better than it ever has done, and yet we are still beset by bed problems and bed pressures.
Are there any indicators yet that this is going to disappear and you're going to get back to normal?
No. I think and I think that's hard actually, because actually we're trying to pace ourselves. I'm very conscious, particularly the acute medicine team. We've cancelled all other activity for the last couple of weeks, so there hasn't been any respite, and there is something around how we pace ourselves, because I think I'm hoping we won't get that terrible peak that we had that first couple of days in January, because that was, I think, even for me in my 30-odd years in this, quite unprecedented. I know 30 years, you can't believe it, but but actually I still think we're going to be at a high intensity right through to, so at the moment we're looking at how we manage some of this through to the post-Easter period.
Can I ask a question around the GP appointments? Because both CCGs got extra money, got some money to actually make more appointments available in primary care. And I was just wondering how you're assessing whether people actually got to know that there was appointments that they could actually ring up. Because a lot of people traditionally think, okay, well, my surgery is closed, I'll hang on till after a bank holiday, and then present themselves maybe poorlier than they should have been if they would have known more about the extra appointments that were available in primary care. So can you outline how you're going to assess that
So the hubs that Helen talked about, certainly for the Greater Huddersfield patch, the work that we did there, that was communicated. So there was a comms package went out to let people know that there would be GP appointments available. What was also made clear, though, is that those appointments weren't for the patient to use directly. So they'd still use the 111 and LCD route, and they had direct booking into all of those hubs, and that's how they were used. And those appointments were used to capacity, so they were using them and filling those slots.
Can I also ask about the ambulance handovers? The ambulance handover times. I'm sorry, my voice is on its last legs, but the ambulance handover times, because looking at the schedule that we've got, there was quite a lot that were greater than 15 minutes, but it changes from week to week. But we seem to do better than some of the other areas as well. So do you want to talk about a little bit the ambulance handovers, please?
The position in mid-Yorkshire is that I've got the data in front of me from the 22nd of December to 3rd of January, and we've been in the top 3 trusts in Yorkshire and Humber for ambulance handover times. But the highest we've achieved was 89%, the lowest was 57%. But even when it was 57%, we were still 3rd in Yorkshire and Humber. So it does vary, but it's massively improved since last year. Massively improved.
So from our perspective, so the information that I think came out from Yorkshire Ambulance is the unvalidated. So from our perspective, just from the 1st of January through to the 8th, we did have 4 patients who waited over 60 minutes. We've had 7 patients who've waited over 30, and then it's probably a 60-40 split between under 15 minutes and 15 to 30. So it is a much better picture than you see, because there's something around when crews clock out versus when we've completed the handover. One of the things that we did do as part of our pre-winter preparation is we have set up a rapid assessment area, so we do have a 4 stretchered area now that's just for the receipt of ambulance patients, which has helped us to support some of the handover. And we also have a facility where patients, when they arrive and they're initially assessed, if actually they can go and book in themselves, then they do go around and they do that. So I think we are in a better position. And I certainly know when we talk to Yorkshire Ambulance, they say if Calderdale in particular starts to see a high number of waits, they know there's probably pressure across the rest of West Yorkshire. It's probably it's a good barometer of if they're starting to struggle, then the system's really starting to struggle.
Anybody have any further questions they wish to raise on this one? No? Okay, thank you very much for your time today. For the panel, there's the TB report. Are we satisfied with the written report? It's just a written report for the panel. Is everybody satisfied with the information that is in that report? The next thing is the work plan. That's as is. There may be some changes in February to the work plan. We will let you know about that when we know. And the date of the next meeting is the 13th of February. So thank you very much, everybody, for attending today, and especially thank you to all those who were already under pressure this month for coming out to our scrutiny meeting. Thank you.